We'd like to welcome Edna and Sarah from Hospicare to do tonight's presentation on advanced care planning. I'm super excited. I think this is a very valuable presentation. So I'm going to let them introduce themselves and take it away.
Thank you so much. We're really touched that you've invited us into your space, and we hope that what we share with you tonight is helpful. Advanced care planning is important for anyone at any stage of life, and we're just really passionate about educating folks. So tonight we have Edna Brown, who's one of our social workers at Hospicare. Sounds like a lot of you already know her in the room. And we're going to be joined by Dr. Yander. Yesterday, she has been at a house call seeing a patient, so she'll be coming into the room, and we'll have a final Q&A at the end where we'll just open it up and have a discussion amongst all of us. So at first I'm going to share a video that's just a nice kind of introduction to the overall concept of advanced care planning between Jen Gabriel, our previous director of development, and Dr. Yander. And then we'll get going, and Edna will share some slides. I'm going to be running tech, and Edna will be doing most of the talking. So you might hear us checking in. Edna, you just feel free to tell me to advance or back up or whatever you need, and we'll go from there. Thanks again, everyone, for being here, and feel free to type in questions or comments in the chat box, or raise your hand if you want to have anything addressed specifically. Okay. Can you all see my PowerPoint slide now?
Hello, and welcome to the Advanced Care Planning webinar. My name is Jen Gabriel, and I'm the Director of Development and Community Relations for Hospicare and Palliative Care Services. Over the course of the next hour, we will be learning more about the important documents that help guide your family, healthcare workers, and other professionals in caring for you at the end of life. We'll also touch on how to have these conversations with your loved ones, as we know how sensitive and difficult they can be for so many of us. I'm delighted to be here with Dr. Lucia Yander, the Medical Director for Hospicare and Palliative Care Services, as well as a practicing physician in our community. Dr. Yander is passionate about this topic for many reasons and has knowledge and experience of the importance of end-of-life planning. Dr. Yander, thank you for being here. I want to start by asking you a simple question. Why is planning for the end of life so important?
Well, you know, as they say, death and taxes. We have all been there, and this is something that we'll have to confront at some point. I feel that it is really important to think about these issues when you're not in a time of crisis. When you have to make decisions at a time of crisis, it is much more difficult to do so. And it's also difficult to make a good decision. So have been trying to educate my patients and in general members of the public about having these conversations well ahead of time when they are really, really needed. There are several good times when you want to have these conversations. Having your annual physical with primary care is a good time to do it. If you're facing a new diagnosis of a serious illness, that would be a really good time to have this conversation. Or if your situation has changed, if your caregiving needs are changing, if there is a major change in your family that would affect how people could care for you and could help you at the end of your life. Having this conversation ahead of the time enables you to put down your wishes the way you ideally would want them to be carried out. And it also enables your loved ones to know what the wishes are, to reflect on them, and to come together to a mutual decision that is known to everybody. And it is really important to put these discussions in writing. Because as you know, if it's not written down, it may not stand. So I feel that it's always a good idea to have these discussions ahead of time maybe multiple times, but do it when you're not in crisis, ideally.
And what would you say is the risk of not making and documenting these decisions?
Well, there are several risks. One is the risk to you. If your healthcare proxies, your family, if they do not know what you want, then they have to guess. And they may have to guess wrong. They may be asking for treatments that you would not have wanted, that may be too aggressive for the situation that you're in. Another risk is actually to your family, because we know that families are in distress when they have to make difficult decisions and they feel that there have never been a conversation about what would you have wanted as a patient. So it creates anxiety and stress for them. And the risk to you is that things may happen to you either too aggressive or too lenient as opposed to what you would have wanted to do. If you don't put these conversations down in writing, there is a process in the state of New York, and a process for healthcare proxy. If you're married, your healthcare proxy is your spouse. If your spouse is unable to function in that role, then it's your adult children. The next in line would be your parents, and the next in line would be your sibling or perhaps even a friend. If there are people who do not have anybody, any family, then the state appoints you a healthcare proxy. And appointed healthcare proxies are knowledgeable people. They are usually members of the legal profession. The downside of an appointed healthcare proxy is that they don't really know what your wishes are, and they have to presume that you would have wanted everything, all aggressive care, even if it may not be in your best interest. What I also want to stress out to people that healthcare proxy and advanced care directive discussion is a discussion that should be held on multiple occasions. Anytime your situation significantly changes, it should be discussed. It may turn out that your spouse would have been a perfectly fine healthcare proxy, but perhaps your spouse is getting older and is developing dementia. Or it may be that your child would have been a good healthcare proxy, but what if they are struggling with a mental illness or substance abuse problem? So it should be reevaluated periodically. In my practice, I try to do that at the times of annual physicals because that's kind of a hard stop. It reminds you that you should always look at these things.
So how do it's a great point to think about having this conversation with your doctor at your annual physical. How do you recommend that people get started outside of that?
It is really interesting that you ask. I mean, sometimes doctors are uncomfortable discussing this topic. And sometimes it really takes the patient's initiative to start a discussion. I think you should think about what would you want your end-of-life experience to be. You should think about your long-held wishes and values. What is important to you? I think these discussions should happen in an overarching setting of goals of care. What are your goals of care at the time when you're having this discussion? And the conversation may be very different for somebody who's in their late 80s and has a lot of chronic conditions, as opposed to somebody who's much younger and may have an acute medical situation that, even though may be very difficult, but there's a good chance that it would stabilize. So think about your life, think about your resources, your support system, your health condition, and about your opinion, how do you feel about end-of-life care? And that should guide your decision-making.
So if there was one thing that you wanted people to take away from this session today, what would that be?
I think the most important discussion is pick a healthcare proxy that you can trust and you have comfort with, and you know that you can discuss what you really wish to do. Your healthcare proxy should be somebody who functions well under stress. They only come into play when you cannot speak for yourself. As long as you can speak for yourself, then everybody follows what your wishes are. So I have had families when the spouses said, I don't want my wife to become my healthcare proxy. This would really be too much of a burden, and she would not be able to function in that role if she saw me really, really ill. So think about a healthcare proxy as somebody that you trust, that functions well under stressful situation, and that he or she will carry out your wishes the way they are. I also think it is important to have an alternate in case your primary healthcare proxy cannot function in that role. And when you're picking an alternate, make sure that the primary and the alternate can work well together. They have similar opinions about your care, and they both work well together on your behalf.
So in addition to the healthcare proxy, are there other documents that you would recommend that people prioritize?
I think especially as people get older, or if they're diagnosed with a serious illness that may be terminal in next 2-3 years, I think it is really important to have a discussion with your doctor about medical orders for life-sustaining care. And if you have seen them, it's the pink form. And that discussion talks about resuscitation, talks about how aggressive do you want your care to be? Do you want any limitations of your care? Do you want a feeding tube? Do you want intravenous fluids, antibiotics, dialysis? Do you want to be sent back to the hospital? That discussion ideally, again, is done in the overarching theme of goals of care. What are your goals of care? And have the discussion with your doctor. I think it is really important while having the discussion that you understand what is your medical situation, and you have hopefully a realistic assessment of what your options are and what the burdens of different treatments would be. And not just medically speaking, medical burdens, but the burdens on your family, the burdens of how much time would you have to spend in the hospital, what are the likely side effects, how this is going to impact your life.
So once I have all these documents in place and I've had the conversation with my healthcare proxy, what do I do with the documents and the information that I've collected?
So, many times these discussions take several visits because when you introduce the topic, sometimes people are, oh, I didn't know I have to think about this. But it's actually really helpful to think about this when it's not a crisis situation. So after you have had a chance to think about these issues, talk to your family, talk with your doctor, and put them down on paper, then you should have a copy of the medical orders for the life-sustaining form as a patient. You should ask for a copy to be left with your doctor. You can send a copy to the hospital. You can have a copy with a family lawyer if you have one.
Great. And, to talk about the sort of tough part of this, often for a lot of people, is how to start the conversation with their family, whether that's their spouse or whether that's the extended family. How do you counsel your patients on beginning that conversation? What are some things to think about?
I think that the important piece is you want to tell your family members, I'm doing this because I'm trying to do you a favor. I'm trying to have this conversation when we have time and we have expertise in our hands and we can really discuss these things. Ideally, don't wait when there is a crisis because it's much more difficult to make decisions in a time crunch and in the times of emotional turmoil. So I would start the conversation as, I understand I'm getting older. I think this is really important to me. And I want to ease the burden on you in case you have to help me making decisions. Sometimes I tell my patients at the time of the physical, it says, it's me who's initiating this conversation. This is really important for you. And if you want to go home and talk to your spouse, then you blame me. It was my primary care who told me that I have to have this conversation. And that may be sort of an indirect way to do it, but it works pretty well.
That's great advice. Well, thank you, Dr. Yander. This has been really helpful, and I want to thank you again for joining us. And I also want to remind everybody that Hospicare is here to support residents of Cortland and Tompkins County, and you can always reach out to us for information or to ask a question. Our website is www.hospicare.org, and the phone number is 607-272-0212. It's now my pleasure to introduce Edna Brown, a Hospicare staff member with over 2 decades of experience in social work, an advocate for advanced care planning, and someone who has counseled many families in how to start these conversations.
Yay, Edna.
Hey, here I am in all my glory there. Now you can advance that one. So we always want to start our presentations with just a little bit about Hospicare in case some of you don't know all of the things that we provide to our community. And we like to start with this quote by the founder of the modern hospice movement. You matter to the last moment of your life, and we will do all we can, not only to help you die peacefully, but to live until you die. That's one of our founding principles there, that we want people to live fully until they die. And we have several programs that can help you do that. So at Hospicare today, we definitely have 3 broad areas of service that we provide to people: palliative care, Hospicare, and grief support or bereavement support. We have a slide on each of those. So palliative care, the people often confuse palliative care and Hospicare, and I always say palliative care allows you to get some specialized services, but continue with any curative treatment, any care you might be pursuing. So if someone has an illness and there's a trial that they want to pursue, that's looking for a curative treatment. If someone has cancer and they want chemotherapy or radiation, or again, clinical trials, those are curative treatments. But palliative care is something offered by Hospicare in our 2 counties that is specialized care. We want to work with people on symptom relief and lower their stress from their illness. Again, look at quality of life. And we have a team of doctors, nurses, and specialists. Palliative care doesn't have the robust encounters that Hospicare does, but there is a nurse manager who then helps kind of coordinate and make sure that all the folks who need to talk to each other are talking. And it is available at any stage of a serious illness. So if you're someone who does have an illness and you're interested, you could call us and ask for a palliative care consult. Hospicare is really a philosophy of care, not a place. Hospicare is specialized medical care for end of life. We are trying to care for our clients, our patients' physical, emotional, social, and spiritual needs. We really focus on symptom and pain management. Some of the questions I ask when I'm doing psychosocial: are you in pain? Do you have any agitation? Our nurses can help manage those. We really want to offer a patient-centered approach that, you know, we may have ideas, we may have experience with a typical trajectory of a disease or end-of-life care. But if a patient wants something, that's what we're going to do. Sometimes we'll offer a hospital bed, and the patient's like, yeah, I want to stay in my bed. We're like, that is fine. But we really want the patient, or if the patient's not able to share their wishes, their Health Care Proxy, to let us know what the patient wants, and we'll give them that. And then when people choose hospice, they're provided support, educational tools to remain in the home environment if they want to. But we can't offer hospice in different locations. I think that's the next PowerPoint slide. Often people in town think of us as the residents up on King Road. Oh, let me talk about the team first. So we'll stay here. Okay, thank you, Sarah. So often people think, oh, Hospicare, that's the place up on King Road. Well, Hospicare is a philosophy of care at end of life. It can happen for your loved one or you wherever the person resides. So if they reside at home, Hospicare comes into the home. If they're in an assisted living facility or skilled nursing facility, hospice comes in there. If someone's in the hospital, we often get referrals from the hospital. We figure out where they should go for us to meet their needs. And occasionally we can offer some assistance when someone's general inpatient in the hospital. And then we do have our 6-bed residence up on King Road that many people are familiar with. We'll go back to the team of people that if we're going to help a patient in hospice with all of their issues, then we have a big team. The person's primary physician still stays involved, working along with our primary nurse, who's assigned and is a case manager for the patient, and our medical director, Dr. Yander. Someone like me, a social worker, is involved to help not only connect with resources, but to listen, to counsel, to provide an ear for both the patient and the patient caregivers or healthcare proxies. We have spiritual care coordinators who approach each patient and family and ask if they would like their connections. Sometimes they offer counseling, sometimes they offer connection to a priest or someone that the family would like or the patient would like to have come and be involved in spiritual care. We sometimes have home health aides that come out and do personal care for patients that need it. We have a 24/7 hotline that's an on-call nurse will call a patient or caregiver back if there's something that happens after our normal hours of service at 4:30 overnight to 8:30 in the morning and on the weekends. Then we're supported by a lot of administrative staff, and that includes volunteer services. And then finally, we have grief support, bereavement support. And again, you see the patient and the family is in the center of all that. And this is their team working with them. We'll switch by the where hospice happens to, this is more about our bereavement support. So some of you may know if you've been in our community for a long time, we have fabulous bereavement counselors. They provide individual grief counseling so people can see them one-on-one. During the pandemic, this has been offered via Zoom. We have support groups. There's a long-running support group that happens every other Wednesday night. But then we also have specific support groups, like Laura Ward will run a spousal loss support group, knowing that it's different for someone when they lose a spouse versus someone else, maybe a friend or a more distant family member. So there are short-term spousal support groups. We try to offer, even in the time of COVID, during the pandemic, we've been able to offer some things, expressive arts and educational grief workshops. We'll have some events for children and teens. Sometimes those will include clay making or circus culture. You may have been to or heard about our community memorials, where we'll have speakers and poetry and music and remember loved ones that have been lost during the year. We usually do that in May or June, and then around December. And then we also, many people don't know, but if someone is a patient at Hospicare and they pass, their loved ones are supported for 13 months after the death. And so there are supportive mailings that go out to the primary caregiver or family member that's been designated, and also mailings and calls from our volunteers and from our bereavement support staff. So I think is that the last slide for there? Okay, so now on to advanced care planning, because that's why you guys are here. These are some great questions, and they're hard questions, but to think about your life, your choices. One of them is, how do you imagine your end of life experience? What are you looking for your last weeks, months, years to look like? What medical or life-sustaining care do you want to have? Some people have really strong opinions about that. Some of their ideas might change as they're educated based on what type of illness they have. One of the questions is, who are your support people? Who's going to be most impacted by your death? Family and friends. And then what do you want your legacy to be? So we have different forms, and someone had a great question of which forms and what's most important. And hopefully as we go through these, you'll see kind of what we feel is like most important. And then some of them are included in other forms. So some forms serve dual or triple purposes. So we'll talk about those. I think those of you who signed up ahead of time are actually going to get maybe some of the forms we're talking about, or we'll get them afterwards. So here's what we're going to talk about today. Making medical decisions, some legal and financial decisions that you can make ahead of time, leaving a paper trail, and we're going to have another seminar in 2 months. It's going to give a lot more info on that. We'll talk a little bit more about how to open up the conversation, have these conversations. We'll talk about next steps, and then Dr. Yander will be here to join us for a Q&A period. So these are the three we're going to talk about the most: the healthcare proxy, medical orders of life-sustaining treatment, the MOLST. If you've lived in another state, you might call it the POLST, which stands for Physician's Orders for Life-Sustaining Treatment, but it is definitely something that you and your physician sign and choose together. And then there's also a DNR, Do Not Resuscitate order. So as Dr. Yander said, the healthcare proxy is a document that designates someone to make decisions for you when you can't make them for yourself. If you are awake, you're not sedated, you're not unconscious, you can make decisions, then of course the doctor is going to look to you for guidance. But if you can't, your healthcare proxy comes into play. It's difficult to know all the scenarios that someone might be called on to make a decision. So that's why it's important to choose someone that really knows you, knows your values, that you trust. And then we'll talk later about a form that might help guide some of those conversations for you with your healthcare proxy. And you want to make sure that everyone knows who your proxy is. If you go into CMC, if you go to your doctor's office, have one with all your important papers and make sure that those closest to you know who that is. So we have here, I believe, the legal document that is suggested by the state of New York. If you go and Google New York State Healthcare Proxy, you'll get these forms, but we can also mail them to you. But if you Google this, there's actually, I think, 3 pages of kind of talking about the healthcare proxy form. So it kind of gives you some tips, like Dr. Yander was talking about: choosing someone you trust, choosing someone who really knows your wishes, choosing someone who's good under pressure, choosing someone who wants to do this. Like, it can sometimes be a job, so you want to make sure there's someone who's willing. And this form can just be signed by 2 witnesses who are over 18. So as long as you have 2 people nearby who can witness your choosing the healthcare proxy and the alternate, and those witnesses can't be the healthcare proxy or the alternate. So 2 other people sign this form. That's all you have to do. You can do it when you're at CMC, you can do it at a doctor's office, or if you want to download this form and fill it out and then get copies to all those places, it's important to have. I do think what I do want to share about this is sometimes people get hung up on who it should be. And I think that I like to look at a group of family and friends around someone who needs a healthcare proxy and say, who's really good in a time of crisis? Who knows you really well? They should be the healthcare proxy. There are other roles for other people. You know, sometimes I meet a family and they say, well, I'm the healthcare proxy. We've talked a lot about medical issues, but my brother, they're really good with finances. So their role is to help mom and dad with finances. So just because you've chosen one person as a healthcare proxy doesn't mean there aren't important roles for other people in the family. And as Dr. Yander said, all these forms are dynamic. Something could change in your proxy's life. I actually have a proxy who may not live in the area anymore. So if that happens, then I will probably be looking for a different healthcare proxy with their blessing. So it's a simple form. You pick a healthcare proxy alternate, get 2 signatures of witnesses, and get them to where they need to go. So the MOLST is that bright pink form. And as Dr. Yander says, it outlines the wishes that you want at the end of your life if you can't make them for yourself. If you don't have a healthcare proxy or they don't know what you want, then this document really guides them. And I like this because your doctor agrees to it. So you have your primary look at it, say, yes, I understand. This is what you want. And I'll make sure that that happens. So it is signed by a doctor and is a medical order. Again, Dr. Yander says you usually do one of these. I'm 60. I don't have any life-threatening illnesses that I know about right now, so I don't have a MOLST. But as I age, and should I have an acute or chronic condition that I think I might need a MOLST for, I'd fill that out. It's a pink form, and I think that's coming up next. It's 3 or 4 pages. And so the important decisions that you have to make on this, and Dr. Yander touched on them, is one is, do you want to not be resuscitated? So you don't need a separate DNR if you have a MOLST form that says, I don't want to be resuscitated. That's on the very first page. And you or your healthcare proxy choose that, and then a physician or PA or nurse practitioner signs that for you. The second page, and I know you can't see all of this, basically goes back to, so do you want to be resuscitated or not? Do you want to be intubated or not? Or would you like a trial period of ventilation? Do you want to go to the hospital or not? Do you want a feeding tube or IV, or do you want a trial period of those things? And then do you want things like antibiotics? And so this is really a great guide for your physician and for your loved ones. If you haven't already talked about each of these issues with them, it's your choices in a medical order. And it's a bright pink form. And again, as Dr. Yander said, most doctors should be asking us each year at our annual about these things, but if they don't, it's okay for you to bring it up. And again, as we get older and as we have acute or severe chronic illnesses, it's a good time to fill out a MOLST form. And they can change. If your choices change, you just tear up the old one and do a new one. So a DNR is a form that says, do not resuscitate me. And basically, we also like to say it's more of let a natural death occur, that we don't want any heroic efforts. We don't want chest compressions. We don't want artificial ventilation. We don't want to be shocked with an AED to restart our heart, that we're ready to just let a natural death occur. So to answer that one question in the chat, if you don't have a MOLST, but you do not want to be resuscitated, then you'd want to have one of these orders, and it should be on file with your doctor, with the hospital, with all your important papers, and your healthcare proxy should know that, because if you're not, obviously, if you're in a condition to be resuscitated, you won't be able to tell them that you don't want to be. So people who are near you should know that that is your request. And often people will put a DNR or a MOLST form, the originals, on their refrigerator, because if someone calls EMS, they usually know to look there to see if there's anything that they should know to guide their actions. Hopefully that makes it clear. If you have a MOLST, you don't need the DNR, it's part of it. Is there a document called advanced care? I'm going to answer this as we go. You know, it's interesting. We're talking about the forms that are part of advanced care planning. None of them have all of the things together. I would say we'll talk about these other ones, but can you go back, Sarah, to that one, and I will finish on that. And did we skip one? Okay, this is what the DNR looks like. It's very, very simple. You can get one at your doctor's office or the hospital. All right, thank you, Sarah. So there's not one form called advanced care planning, but these forms are part of it. And based on your situation, we can tell you the ones that you need. Again, if you have a MOLST, it already asks the DNR question, so you don't have to have a separate form for that. But there are legal and financial forms that are also part of advanced care planning. We kind of talked about the medical forms, and these include the durable power of attorney. So if you give someone power of attorney and you are suddenly unconscious, they can write a check out and pay your mortgage or your insurance or the hospital bill. And this is something that should be discussed with an attorney. The durable power of attorney gives someone a little bit more power, I believe, after a death. So that's something that would be drawn up and you should talk to your lawyer about, and they have to be notarized. A will indicates how anything that you have, your assets or estate, will be distributed upon your death. These do have to be done by a lawyer, or there are some forms that are offered online. I actually haven't used one of those, but you might be able to talk to a lawyer about filling out the basics maybe, and then getting that to them if you're worried about the cost of a will. And also New York law provides legal services. It used to be called legal aid. And for some people who qualify financially, New York law might be a resource for you. A living trust provides instructions about your estate and assets when they're just not going to all be given out to people. They're going to be kept in a trust, and the executor of that trust will distribute funds to the beneficiaries as you have decided. Often people do this if they have children who are underage and they want to provide for them, but they don't want to give a blank check to a 19-year-old. They'll have assets put in a trust, and someone else. Yes, so I have been told, yes, that a POA ends when you die, but I did see something called a POA with a something rider, and I think that's the durable power of attorney, but I can follow up on that and check for sure. But that's why I say these are legal documents, and I am not a lawyer, so they really should be talked about with a lawyer. But a lot of people think that the power of attorney ends, I mean, that they have it after the person's death. And if you look at a power of attorney form, if you print one off for New York State, it's got lots of little checklists. And one of them does allow someone to make a couple payments of something after the person's death. All right. Moving on. We put this in here just to educate people. If you are interested in being an organ donor, you can put that on your, you can fill out a separate card. You can have it on your license. I will tell you, I've learned, being in hospice, that people who are on hospice can't donate organs because there is no artificial keeping them alive. So that is one kind of caveat, that our hospice patients can't donate organs as such, but they can do eye and tissue donation. And many people think about Upstate and their anatomical gifts program. So Upstate Medical has a program that you can pre-register for if you would like your body basically to be donated to science. It's used in one of the medical programs in Syracuse, and then cremation occurs and the cremains are given back to the family and loved ones. So I believe I wrote it down, March 15th, we're going to have another one of these workshops. Do not be turned off by its name. I don't even know if we have a name for it yet, but some of the folks who've done this before in the past have called this the death binder. Maybe it's called your emergency folder or your important 3-ring binder, but it's really important to leave a paper trail. And the person that's closest to you that is going to be left behind, or if you're the person who's going to be left behind, and we're talking about a spouse or parents that you're thinking about as we talk about these things, at some point somewhere you need to know where bank accounts are, insurance policies, investment details, safety deposit box keys, social security cards, all the important papers. It's important to know their utility and monthly billing information, mortgage deed, lease for the home or residence, vehicle titles, internet accounts and passwords. I'm not all that tech savvy, but I know there's something, and someone can probably pop it in the chat, that is basically a place that you can keep all your passwords. And then you just have to give that password to your loved one, and they'll be able to open up and see all your passwords. Important phone numbers for family members and friends you might want to be contacted, doctor, pastor, priest, and your preferred funeral home. If you haven't made those decisions and plans already, it's important to leave that information for others. And this was added. Don't forget to travel with the MOLST and the DNR if you're in a precarious situation. And then also you might want to make sure that they are honored in another state. So I know a lot of people are snowbirds, and they may live 6 months here and 6 months in Florida. So you want to make sure that you have the documentation that is considered legal in each state. Okay, I'm going to answer this one question as we go, if it's okay. Is there an age when being an organ donor no longer makes sense? I have heard that they can use organs at quite some age. Usually, definitely eyes are usable. I do know that there's a cutoff on eyes, which is 70. And so, again, I think it matters what condition the organs are in. If you're someone with congestive heart failure, your heart probably won't be usable, but maybe your kidney or liver would be. So you might want to check into that. We can probably give a copy of the slideshow. We'll let Sarah answer that. And there we go. I knew someone would know. Thank you, Monica. LastPass is a secure password saver for computers, phones, and tablets. All right. So we've talked about healthcare proxy is really important. MOLST is really important, and the DNR is contained in the MOLST. If you don't have a MOLST, you can have a separate one. There are lots of sites online where you can find some information. One that I really like is called 5 Wishes, and this was started by a guy who realized that people don't always have these conversations. They're tough, and that we needed some kind of guidance for this. So they developed the 5 Wishes. It's not a legal document exactly, except you can name your healthcare proxy in this form and have it signed by 2 witnesses, just like a separate healthcare proxy. So this is one of the forms that includes another one, and it's legal in the state of New York. What I find is most important about this document is that it really guides your healthcare proxy in thinking about different situations, so that if one of these situations comes up, they've already had that conversation with you. So I forget if we have the pictures of each page, but if not, I'll kind of talk through them. Do we? Okay. Let me just say a little bit more. You can say right there, Sarah, but say a little bit more about 5 Wishes. It basically says, if I'm sick, I want people to hold my hand, offer massage, wet my lips, like really down to some nitty gritty. But it's important for us to be able to express what we want at the end of life. And 5 Wishes allows you to do that. It lets you name someone to make decisions when you can't. It actually asks for other things like you circle the ones you want, or you cross out the ones you don't want. And it says, I'd like massage. I would like people to play music for me. This is the kind of music I like. There's this form, a section on the form that talks about like how I want to be remembered. I want my loved ones to remember this about me, and how I want to be celebrated or not celebrated in a memorial or funeral. So the beauty of the 5 Wishes is it's going to talk you through a lot of different scenarios. And the healthcare proxy ones are kind of like, if something happens and they think they'll have full recovery, I'd like everything to be done that can. If something happens and there is no chance or very limited chance of me recovering and living a normal life, I don't want intervention. So it kind of breaks down those types of scenarios. Then the Five Wishes website also offers some other conversation starters. I don't know if each of you are thinking about yourself or a loved one. I know in a lot of our advanced care plannings, we have young to older adults saying, I wish my parents would make this decision and tell us. So whoever it is you're thinking of, here are some conversation starters. One is, there's something on my mind and now's a good time to bring it up. I mean, at the beginning of COVID, we did a lot of these, and it's like, people were dying that didn't expect to die. And so it was a good time to kind of say to the loved ones, we don't know when our time is up. Let's talk about this. If you're offering to be the healthcare proxy or to fulfill some people's wishes, you could say, you can count on me to be there for you, but I really need to know what you want. The next one, I want to do the right things for you when you need them the most. So I need to know what they are. The fourth one, I don't know your wishes, so please tell them to me so I can honor them, whether I agree with them or not. And that is the really defining factor of the healthcare proxy. If you don't want to be resuscitated, you don't want to choose a healthcare proxy that can't also abide by that wish, right? You really need them to be in tune with your choices and be willing to support those. And others just say, you matter to me and I care about you. So I want to know how I can help if you're ever sick or at the end of your life. So a twist the other day, I talked to someone who's older and she said her children don't want to talk about it. And so we could go back to also what Dr. Yander said. I really do believe this is a gift. If you've ever had to deal with the death of a loved one and didn't have any of these forms or documents or their wishes available to you, it's a really tough thing to do. So I think you could say to your parents, please give me the gift of advanced care planning. Let me know what you want so I can follow through with that. Or to say to your children, I'm giving you the gift of advanced care planning. I want you to know what my wishes are. So when my mother passed and I sat at the kitchen table making funeral arrangements, states away from her, I told my young children, I'm like, you will not have to do this. We'll have it all planned out. And we do. So what is next, Sarah? Okay, so if you're going to be really proactive on this, the next steps would be to print out the healthcare proxy form, decide, think about, talk with your loved one, your partner, or your closest friends, or your adult children. Figure out who you want to put as the healthcare proxy and the alternate. Get 2 witnesses, not the healthcare proxy or the alternate, to help sign. And then get copies to your doctor, to your family, to CMC if that's where you go and get your care, another hospital if that's where you go. Use 5 Wishes or another online format to kind of guide your conversations. Consult an attorney to put the POA, the will, and the living trust in place. And I know that it can be scary talking to attorneys, and it can be expensive. So, you can do some research ahead of time and look at sample POA forms and sample wills. And if you have to have a living trust, you're probably going to be talking with a financial advisor and a lawyer. And then fill out your MOLST with your physician if necessary. So again, Dr. Yander said if you are advanced in age or you have a new diagnosis and something that's acute or maybe it's going to be chronic and you think that a MOLST would serve you well, you can fill that out with your physician. Also, always knowing, that each of these forms is dynamic. If you decide you want someone else to be your healthcare proxy, you tear up the old forms, you get the new forms in place at places that you put them, your doctor in the hospital, and you can change that fairly easily. The same is true of some of the other forms, the MOLST, you could just tear it up and start a new one. You have to go through a few more hoops if it's a will or POA, but know that these are dynamic, that if you do it and you change your mind, you can just have them revised. So I don't know if Dr. Yander is with us yet. Is she?
She is.
Oh, good. And hopefully I've answered all those questions in the chat. Sarah's going to share the slides with Monica. LastPass is a secure password saver. Yeah, okay. So now you get to pick our brains and
I would say feel free to unmute. This can be very much a conversation. So either put it in the chat box or just, you know, we're a small enough group that I think we can just kind of navigate it like a normal conversation if we're in a room. Richie?
So I've looked at some of these forms and I get stuck really quickly because I don't really know how I'm going to feel when I'm in that situation. So I don't even know really how to start. And I've looked at it a couple of times and I end up just not knowing what to do next.
I think you are highlighting a frequent ethical conundrum, the current self, the present self versus the future self, you know, and you can change your mind is one of the things that I would say. And I think that the forms are meant to be a prop for a conversation with your doctor and with your family. I don't think that you should sit down and try to decipher the form on your own. And sometimes I think it's helpful to have a conversation in broad strokes. If I were to be in a situation, I cannot communicate, I'm bedbound, I'm moderately to advancedly demented, what do I think I would have wanted? Sometimes it's helpful to at least have that conversation, because if the situation were to happen and you've never talked to your family, about half of the times they guess wrong.
I'd also say, you know, start simply, the healthcare proxy, pick a person and an alternate. Someone that, you know, a family member, a good friend, and just get that one done. And then I personally like the 5 wishes form to sit down and talk with them, because it does kind of guide you through some of those scenarios. You know, I like to say to people, I don't have grandchildren yet, and my life goal is to have grandchildren. So I want all the stops pulled out, you know, because I want to see these grandkids. But if I'm 90 and I have advanced dementia, I don't want people doing all sorts of interventions to me that I'm not going to have. I know I'm not going to have the quality of life I want if I have moderate to advanced dementia. So I would choose differently what I put on the MOLST in terms of do not resuscitate, do not intubate, do not hospitalize, than what I intend to do now. So, and Richie, you know, you might even get a group together if you wanted. I went to the Death Cafe, which happened quarterly. I don't know if you guys have heard about those. And my group got off on this conversation about the 5 wishes. And we made a decision that the 6 or 8 of us were going to get together, do them together, witness them for each other. And we did. We just made it happen. So maybe, you know, I also have a friend that I do this kind of stuff with. We do it for each other. So on our list for Friday is to do a healthcare proxy. Fun times when you're my friend, but again, rely on your loved ones and your friends and see if you can get that done, at least a healthcare proxy.
You know, one thing I would mention is if you do nothing, there's a default. So
Yeah.
by electing to do nothing, you've already made a choice, you know?
Yeah.
And the default is the most aggressive care. You know, if you have no limitations, then you get the most aggressive care. And the default in healthcare proxies is as stated in the New York State family law, you know, spouse, and then it goes down by, you know, as it outlined in the law.
Mm-hmm. And I would say check, because when I last went for just a routine thing, I asked who my healthcare proxy was. I knew I'd filled one out, and they told me it was my ex-husband, and I was like, let me have that form now. And I did. And honestly, if you have been separated from a spouse for 40 years, but you're still married to them, they are the first in line before your adult children. So better to choose than to be chosen for. And then someone else asked if they need to be local. I don't think it's necessary. In hospice, we have lots of healthcare proxies that maybe are in other states, particularly if it's our patient is an older person. It's a little bit tougher sometimes, but as long as that person can get to the phone and talk to the people who need to talk to them about your wishes. I'm actually a healthcare proxy right now for someone who's at Rochester General. So I call. I'm not at Rochester General, I'm working, but I'm calling regularly and they have my phone and they could call me. And so it's really up to you. Again, I'd ask if that person wants to be, right, your healthcare proxy, if they're willing to do that. And then if there's someone who's accessible, right? Maybe someone who's a brain surgeon who's in surgery 15 hours a day might not be very reachable, right? But if someone else is able to pick up the phone anytime, then I think that would be okay. Dr. Yander, do you have any other thoughts on that one?
I don't. I don't think that the distance matters. I think it's really, do you trust this person to make decisions on your behalf? It's really a trust question, and is this person capable of doing this? Because this really tends to happen in a situation that are hard. They have to make difficult decisions. So I don't. They, they're a phone call away. Whether they're in Ithaca, whether they're in Florida, it doesn't really matter that much. Mm-hmm. Sometimes when I have very elderly people, the out-of-town family member does not sometimes appreciate how limited or how difficult somebody's life could be. And in those situations, I think it's more helpful to have somebody who kind of knows the ins and outs, the day-to-day functioning. I think they tend to be more realistic, but I don't think that they have to be local as long as they respond to a phone call. It's really, do you trust this person and are they capable of making tough decisions?
What?
Other thoughts or questions? We can have a conversation. It doesn't have to be just questions. Yeah, is that Claire? You have to unmute, Claire.
Is it? I forget now on the healthcare proxy form. Can you list? You said 2, and I was wondering if you could have more than 2. And can you make them equally able to act, or is there a hierarchy?
Mm-hmm. Dr. Yander, would you like to take that one?
Yes, you can. You can make more than 2. It's sometimes I tell people, be careful what you wish for, because you may have too many opinions and then people just get paralyzed and nobody makes any decision. If you name several people, just make sure that these people can get along with each other and they have a similar outlook on the situation, that they really carry out your wishes. I don't think that there's a hierarchy.
And I wasn't necessarily planning on having them all make the same decision. I was going to be okay with any of them making the decision. But I have currently my healthcare proxy person is in Maryland, and I was thinking having 1 or 2 people in Ithaca.
Yeah, I would just say I put them in order and not have like 3 friends decide, because or 3 children decide, because they really need to come to consensus. If they are all the healthcare proxy, it's nothing in the law says, oh, the oldest gets to decide, so
yeah. But on the power of attorney, you can have them act independently, and so that would be fine as far as I'm concerned.
Yeah.
It's just that different people are better for different things. So.
Correct.
I'm not sure that the healthcare proxy functions that way. If you fill it out, the person who's on the top of the list is the person that people will talk to, and you would only go down the list if you cannot get a hold of the person, or if they cannot make a decision, or if they ask you to go down the list.
Yeah. Well,
I don't think that you can say, I want a healthcare proxy that deals with my cognitive status, and I want a healthcare proxy that deals with my surgical status. I don't think it works that way.
No, I do understand that. But I'm just thinking that I have different people who might be better, and they may talk to one another or they may not. But maybe I'm trying to make it too complicated.
I think that if you have people that you trust and you think that they can make good decisions, this is all fine. I always warn people, if there's an extended family, multiple family members, and some of them have really different opinions about things, and not having a healthcare proxy in a situation is dangerous, and listing multiple kids who potentially don't get along is also a recipe for a disaster. And what I tell people is, pick one or two and tell the others that I picked X, Y, and Z, and I didn't pick you because I don't want you to have to do the burden or something like that. Just be very explicit about what you're doing, that people don't feel left out.
And usually people know if they can't or will. My mom lived with my sister for 6 years. It was a perfect arrangement. My sister could not be the healthcare proxy because she couldn't follow my mother's directives, and so I was. It was perfect. My sister got to provide the care. I got to be there when hard decisions made, and it fit both of our skill sets. We each had a role to play.
Edna.
Thoughts? I wonder if we could do a show of hands. I'll have to flip this. How many people do have a healthcare proxy right now designated? Okay, keep them up so I flip and I can see. Okay, good. That's a good number of you. Okay. Has anyone ever looked at the 5 wishes form?
I'm going to.
I will.
Yeah. And even if that's not what you decide to use, though, again, I think it covers a lot of things. At least it's a great conversation guide, that it gives you some scenarios that you're talking about. And it also talks about things like, what do you want at the end? Do you want people holding your hand? Do you want them playing music? Do you want prayers, right? Or do you want someone chanting? So it gets down to some of the nitty gritty. But if you've never had these conversations with someone, then I think it's important to have them so that they know what you want.
I just want to point out that the 5 wishes has no legal standing. If you need to fill out the healthcare proxy form and the MOLST form. If the 5 wishes is a great conversation starter, and the conversation is absolutely critical piece of the decision making, but make sure that you formalize your decisions and put them on paper in the forms that are recognized in New York State.
I looked at the MOLST form a while ago and was, like Richie, rather daunted by it. And I'm hoping that the 5 wishes form will help me do that. I sort of thought that I had to wait to do that until I was a bit iller than I am right now, but you said 2 to 3 years, so.
I think it's very individual. There are also people who have very strong opinions. They may have seen a loved one go through some horrendous hospital course, and they have very strong opinions what they want. And I have had younger people who just said, this is what I need to do. The MOLST form is supposed to be filled out by your doctor. The MOLST form is complicated. And even I, as a doctor, have to, kind of think about it and really explain to people what are we doing. So don't feel, it is absolutely daunting, but it's supposed to be filled out by your doctor or nurse practitioner, not by you. And they're supposed to be talking to you and, trying to establish what your wishes are and then formalizing them on paper.
It sounds much more helpful than the healthcare proxy. I do actually have a living will from years ago, and I've been sort of advised to get rid of it, and I'm a little bit nervous about that. I'm not too nervous, but a little bit nervous. It sounds as though the MOLST form is basically doing what my living will does, more carefully and in a more medical terms. So that
Right.
sounds good.
And it's a medical order, right? They have to follow it.
So what I want to remind people is the MOLST form, if you filled out the MOLST form with certain wishes and suddenly you're in the ER and you cannot speak for yourself, the providers are supposed to follow what's on the MOLST form. So if you have disgruntled relatives who shows up and say, well, actually, I don't think that this should happen, they will listen to them, but really they are supposed to follow the MOLST form. So it is a binding document in that sense.
So my father, he's been gone for several years now, but he had an unexpected massive stroke. And we were at the hospital and he didn't have a MOLST form. He didn't have any of this stuff. And I had to work with the doctor to fill out his MOLST form. We had him intubated so that he would stay alive long enough for my brothers to get here from South Carolina. And I had to fill out the MOLST form with the doctor, and it was hot pink. And they kept telling me, well, what do you know? Because I was with them almost every day. I knew his wishes. I knew just from talking to him. But I don't even know if that was legal. Like my brothers were like, how did you know this was what he wanted? Was that right? Like now I just want my MOLST form done. I want to have mine on file. I don't want to put my children in that position. It was very awkward. And I don't even know if it was legal. It was a local hospital, not in Ithaca, but it wasn't too far away. And it was scary.
I think you're describing exactly what you're trying to avoid for your family members, that somebody is not put in a position that they have to guess. But I think it is legal, because if the person cannot speak on their behalf, then by default, who's the decision maker? If they have not named the healthcare proxy, it's spouse, and then you just go down by the hierarchy as stated.
I was the oldest child and my mother had dementia, so I guess it fell to me.
Yeah.
Okay, thank you, that helps. It was really awful. It makes me know I need to have that done and on file. Yeah.
And I mean, you bring up a good point. It also can be dynamic, right? It's like, if you didn't have the brothers, you might not have ever put him on ventilation, right? But you knew that you wanted to do that and keep him there. So that would be a trial period of ventilation, so that they could see him to say goodbye.
Yeah.
It would be someone who didn't have that happening, right? They might not have chosen that. Yeah.
That's right.
So if you have a healthcare proxy and you have a MOLST form that you've filled out, the healthcare proxy comes in and says, I know that Claire doesn't now want what's on the MOLST form. Does the doctor have to do what's on the MOLST form? Because that seemed to be one of the problems with the living will, was that the healthcare proxy had to do what was on the living will, and instead of doing what they thought was best for you, or that you would have wanted.
The MOLST is supposed to supersede. It's like a standing order that's signed. Does it always happen in practice? Not always. Not always. And is that right, that it doesn't always happen? Probably not. There's a lot of decisions that, the situation changes. But what I tell people, this is supposed to be a standing order. And the most common situation that I have encountered are people who have advanced dementia, or and they have made a decision years ago that they do not want aggressive treatment. Suddenly something acute happens, and it's usually the kids who come and says, well, actually, I think it would be better if you tried X, Y, and Z, put the person in the ICU. And then there's this conflict. But technically the medical team is supposed to go by the MOLST form. Somebody is not supposed to be able to show up in the ER and undo your wishes.
Yeah. But one way maybe to get around that, if I didn't want to do it, is fill out the MOLST form but not have it signed. So then I could give that to the healthcare proxy and say, this is what I think I want. And then,
but it doesn't have any standing. It's either filled out or it's not filled out.
No, but it tells them, gives them a lot of guidance as to what I might want.
Yeah, I think it's the conversation that's the important piece. And I always tell people, you cannot think of all the permutation of terrible things that can happen to you in life. I mean, that's just impossible, this shouldn't be an exercise in catastrophizing. This is sort of broad strokes. If I cannot speak, if I cannot communicate, if I cannot move, what would I want? Would I want aggressive interventions? Would I want kind of middle of the line, you talk to my proxy, or would I just want comfort? I think that makes
Yeah.
the most sense, because you cannot predict all the random things that can happen to you.
Now that's why having a healthcare proxy that knows what can think for you, that's
Yeah.
comforting.
Exactly. I should add, we just had an interesting in-service that if at Cayuga Medical, there's an ethical committee, and if there is no one there to decide what should happen with someone, the ethics committee gets together and they try to gather any information they can from friends or acquaintances or coworkers, but they end up making the decision if all those people Dr. Gander listed aren't available. I did see another question in there, and it says, what about having the healthcare proxy and MOLST if you want to donate organs? So to donate your body to upstate, you don't have to be kept on a machine. Death happens, upstate is notified. The same is true of eye and tissue donation, but organ donation, right, Dr. Yander, you would need to be on life support. They would keep the organs.
Well, not necessarily. You can, harvest deceased people's organs. Actually, one of the biggest sources of kidneys, in sort of a tragic twist, are opiate overdoses. People who died of opiate overdose. So I don't think that, most people who elect not to be resuscitated in this sort of section of a MOLST form are ill and frail and very old, and on a practical level, not a whole lot can be donated that would be of use. I mean, without sounding crass, so and practically it's sort of a moot point. But you can have disease kidney donation. I mean, that happens. It's not mutually exclusive. But the vast majority of times, in somebody dying of hospice, then obviously there's not a discussion of organ donation. Because I mean, you go to hospice because you're unwell. I mean, it's a service for people who caters to dying people.
I have a question that's just a practical, quick one. I believe somebody said along the way that if you get these original forms filled out and signed properly and notarized or whatever has to be done, excuse me, you can then make just regular old copies and distribute them around to your various doctors. Is that correct? That
That's
you
correct.
don't have to have all originals?
That's correct. They don't have to be notarized. There needs to be two witnesses, but usually, like let's say in our office, I'm one of the witnesses because we filling out the form, and then I have another staff member to come in and we just sort of go over the form and the staff member signs it. It doesn't have to be notarized.
Right. Well, that's good. I wanted to make sure that carbon copies or whatever we call them now, Xerox copies are still okay. Since they're not.
I think so.
It's the power of attorney that needs a notary, and a will needs a lawyer.
Yeah, we haven't had it much in Ithaca, and this really should be a quality improvement project. But there's a statewide push for electronic MOLST forms. That it would live somewhere in the cloud, and if you show up in a random emergency room, they can just pull it up and see what your wishes are. A lot of the areas of New York State are much further along in this project. Locally, this is all still paper-based. But at some point, hopefully we'll get to the point that we'll have electronic MOLST forms.
Monica, was there another question? Kim, did you have one?
I was just going to say, one of the points you had brought up that, it's a good thing to have the discussion when you're not in the midst of an emergency. And I found that to be true when I was first diagnosed with cancer. I was a wreck, and everything in the house has got to be done. I've got to update my will. I was really on a tear because I was very, very nervous about it. And I only have my daughter, who would be my survivor, and she was 25. And I tried to have the MOLST conversation with her. And she just shut down completely. It was way, way, way too much on top of, a new cancer diagnosis, surgery, radiation. It was just too much. And, things have changed since I originally tried to have that conversation. And I was just thinking, yeah, that was not the time to say, hey, you're going to be the one making these decisions probably, or relying on someone to help you make those decisions. But now that things are different, I'm like, oh, I got to go back and do that when we're not in hysteria, because you're not, maybe I was thinking clearly. I want everything all tied up and neat and tidy. I don't want to burden my daughter with all these things, but she wasn't in a space where she could be thinking about, oh my God, I mean, my mother's sick. That was the first thing that blew her mind. And then to think about, well, what if she's going to die? I mean, it was horrible. So I can definitely say, do it before there is pending doom or potential doom, because other people don't handle it well, or at least that was my experience, that it was too much. And I mean, my daughter had a meltdown. It led to really hard feelings. And I thought I was being, so terrific in planning, and she was just horrified and angry and upset. I mean, she went through it all. And in hindsight, yeah, I can see where wait until things mellow out a little bit and you can talk more calmly, and
Yeah.
you're not in the midst of a disaster. But on the other hand, not having it done, it's horrible. So you have to do it.
And I'll chime in because I'm in a similar situation, Kim. I don't have a diagnosis, but my kids are 22 and 23, and I didn't want them to have to make that decision. So I chose a really close friend. And when I asked her and she said, yes, she said, but of course I'll be talking to your children. And I love that. She knows my children and knows them since birth. And so she would be the one who would have to actually say my wishes, but she could do it in consultation with them. And, I'll wait till they get a little bit older before they get put.
And I even thought about having another person that I know. And then I was thinking, this person telling my daughter what was going to happen, I could see that not working either. I mean, I was trying to make it all happen at a certain time because I wanted everything neat and tidy in case everything went south and it was horrible. And I mean, as we played it out, it was just like, oh gosh, this is, there were friends who would have been maybe good in that position, but for my daughter to be hearing from them, oh, this is what your mother wanted, that wouldn't have worked either. So yeah, very, very helpful information here. And I had not heard about the 5 wishes. My parents are elderly, and my sister and I have been, trying to get their things in order, and I'd not heard of this. And I can't wait to really look at it more closely, because it's time for us to update our discussions with them about, what happens next as their health is failing. So excellent information you've shared here. Thank you so much.
One thing I would say, you don't have to make any, unless you're in the ER in some kind of emergency, you hopefully don't have to make these decisions on the spot. I mean, this is an evolving project. It's a conversation. Where do you see yourself? And I usually start with, so where do you see yourself? What do you think is going to happen? And, a lot of times people kind of know, like, my health is failing. It's not the same as last year. It's a good conversation starter.
Yeah.
And just have it over several sessions, because it is a hard conversation for people to have. And a lot of people just sit down like, oh, I want to talk about this. It's like, okay, well, maybe we can talk again.
Yeah. And, in 2 months, we're going to talk more about all those things that should be in a binder or a file. And so that would also be good information to say to your parents, we really need to know where things reside. We don't want to miss anything, and just get all those put together. There was another question in the chat. Someone said, I mentioned this group that gets together to talk. It's actually called the Death Cafe. It's an international movement. It's basically to destigmatize death and dying. And so they have these kind of quarterly salons, I guess, and the woman who runs them is called Angela Menino. And I can always, Monica or Kim or whoever would like, I can always give them the contact if you wanted to share that with people. And again, it wasn't their intent for that day, us to fill out the 5 wishes. It's just our little group. We're really thoughtful about, we want to do this. How will we do this? Knowing that it's hard to do if it's just on your to-do list. So we made a date and we all got together. But yeah, definitely, if that's something that interests you, having conversations, it really does destigmatize. We are all going to die. And that's what I love about working at hospice. It's like, it's just a given. So we are helping people have the best quality of life that they can until that last breath. And changing the way people see and talk about and think about death. It's important to us. So, Helene, were you trying to raise your hand there? You have to unmute. Helene, you have to unmute. There
Yes.
you go.
I wanted to underscore one of the points I heard mentioned this evening, and that is that whatever decisions are, let's say they're being made now, will change given your situation. And I'm sitting here and thinking about what I experienced with my mother, who did die of 95, but when she was 94, she had surgery. And she didn't have any of these things, advanced directives or MOLST or nothing. But the doctor came in. And the reason I'm saying this is if she were 65, she would not have answered the same way. And my mother was a person who said, I want to live, because she did. And she lived a very difficult life. And she was a survivor, okay? And so she said to the doctor, yes, I want everything done. And she was in the hospital bed and we were standing around, and the doctor handled it very nicely and said, okay, everything, would you, and I'm trying to remember how this progressed, but he explained, he said, how about CPR if your heart stops? And she said, yes. And he said, well, you know, she was about 195 pounds. No, she was 95 pounds, not 195 at that time, and quite frail and 4'11". And so he explained what compression on her chest would do. And she said, no, I don't want that. So 20 years earlier, she would have said absolutely yes, and that would have been correct. And then he went on to say, well, if your kidneys fail, should we hook you up for, renal treatment? She said yes. And she said yes to the other things, but she also said no to something that the doctor explained to her would be much more debilitating than she ever wanted. So at 65, yes, do CPR on me. At 95 and 90 pounds, no.
No.
So we've done, my husband and I have done power of attorney and healthcare proxy, but we haven't done MOLST. And Richie, when you were talking about how difficult it was to do it, I started thinking about how this changes. So it may be, I can't anticipate, as Dr. Yander was saying, I can't anticipate what kind of situation I'll be in even 2 years from now. But I really appreciate this session, because I'm a procrastinator, and this is helping me to not be a procrastinator. So thank you.
If I could make a comment, this was an excellent comment. I think, and this is incumbent on doctors, and if they don't do it, you should ask them to do it. Could you tell me, in my situation, the way you are, whatever your problem is, what are the options? What are the chances of these different options working, and what kind of implications this would have for my life? If you sign up for dialysis in your 80s, we have good data that, your mortality is very high, your quality of life goes down, you become functionally dependent. I mean, this is not, do you want to have everything done? I mean, this is not a buffet. This is like, if you opt for option X, Y, and Z, this is what you can expect. It's really important to have the whole discussion. Like, what are these options? What kind of baggage are these options coming with? And, we know that out of hospital resuscitation for people in their 80s or 90s, well, the chances of even surviving it to the ER are less than 2%, or maybe even less than that, So the question that I have with people, it's like, it's highly unlikely to work anyway. Do you really want to go through this? And then, that's kind of all comers, elderly, frail people who have out of hospital cardiac arrest. I think in order for the patient to make an informed decision, you need to know the information. It's not just kind of, do you want to have everything done? I mean, that is a pointless conversation because you don't really have the information that you need to have that's pertaining to your specific situation. So if you get kind of a vague question like that, then you ask the medical professional, well, tell me how would this look like? What would my life look like? Like, how well would this work? What would I have to do? If you, and ideally you do this when you have that luxury of you're not sitting in the emergency room with something acute that the decision has to be made in the next 2 minutes, you know, that you can think about these things.
Sarah has put in the chat a form that you can fill out if you want the 5 wishes form. Is that right, Sarah? Did I see it?
Yeah, we can send you a copy. So there's just a simple request. I'll put it again at the bottom.
And I'd also throw out there that, you know, often we get calls from people who have questions about palliative care, hospicare, and we will find someone to answer them, right? You don't have to be like ready to sign on for either of them. You can get more education, and we're happy to do that. That's why we love coming and talking to community groups. Great.
Okay. Sarah, could you send that link to me? And then I can send it on to anybody who might need it.
Sure.
Thank you.
Any other questions? Comments?
Thank you.
This
You guys
was
did great. You're
wonderful.
so engaged. We'll see you in 2 months, I think, right?
Yes.
Sarah,
Yeah,
say more
that'll be
about
great.
that.
So we'll have Edna talking about having the conversations, and then myself and Wendy Yetro, our volunteer manager, talking about the paper trail.
Very good. Yeah.
Thank you, everybody. It was great.
Yeah.
Thank you.
Thank you.
Okay.
Great
good evening.
information. Thank you.
Bye-bye.
Everybody stay
Bye.
warm.
Take care.
See you next time.
Thanks, Monica.
Yep.
Thanks, Jen.
We'll be here.
All right, bye.
Bye.
Ay, ay, ay.